All right, we can get started. Hi, everyone. Thanks for coming to Northwest Missouri AHEC's first health career chat. These chats are going to be the last Monday of every month, and they're going to cover different careers in healthcare, and we'll be interviewing people, having good group discussion. So we hope that you plan to attend more of our health career events. Today, we are featuring careers in surgery. We have with us Dr. Schwabe. She is a cardiothoracic surgeon at Northwest Missouri, or at Mosaic Life Care in St. Joseph, sorry. And she's also a board member for Northwest Missouri AHEC. So we are very appreciative of her and can't wait to hear what she has to say about her career. Dr. Schwabe, is there anything else that you would like to say to kind of introduce yourself?
Okay, it wouldn't let me unmute, sorry. Had to have your permission, Savannah. I'm a cardiothoracic surgeon at Mosaic, and I've been there for 20 and a half years. I finished my training. I did med school at Creighton and finished there in 1989, and then I did general surgery residency at Creighton, finishing in 1995, and then I did cardiothoracic surgery residency and finished in 1997. My first practice was in Kearney, Nebraska, and I was there for about 3.5 years. And then I've been at Mosaic since then, or Heartland before we changed our name.
All right, so first question, why did you decide to pursue this career?
Well, I don't know, other than I think probably believe God put me in this path. I went to med school initially thinking I wanted to be an OBGYN. Thought that I would want to deliver babies. I didn't think I would like surgery, and I didn't think that that was something I'd want to do, but I really thought I would like delivering babies. But things were different back then. You didn't do job shadowing, and I really didn't have any experience in medicine other than my family practice doctor and a couple things in college where I went and like volunteered in the emergency room and things. So it wasn't really until I did my surgery rotation third year of med school that surgery even really was appealing to me. And then as I just got further into training, cardiac surgery was really what drew me. Just the disease processes. I really like, not that I like sick people, but I like taking care of sick people. I like kind of the way I don't think I'd make a very good doctor that, treats hypertension and sees how you do in 3 months. I like more of the immediate feedback of what surgery does. It fits more my personality. So cardiac surgery and cardiothoracic, I do hearts and lungs. It's really just what spoke to what I like to do. And then found out I actually have, talent as far as my, small motor skills and things like that. So, but ultimately, I think it was God directed me to this path, and that's how I ended up here.
So you mentioned that you wanted to be an OB originally when you were in med school. I think a lot of high school students or undergrad students, even when they get into medical school, they might have an idea of what they want to be. Do you have any advice for students in this position? How do you stay open? How do you kind of know that this is the field that you should be getting into?
I think even going all the way back to high school is to just keep yourself open, because I know there's a lot of kids who go to college intent on some specific career, and I don't know the statistics, but majority of people change their majors before they graduate. They may not change their ultimate career, but they'll change their majors. So to just go in with an open mind, because things may exist. Like, I don't even think cardiac surgery was on my list of things that were even possibilities. I guess I thought that, that somebody somewhere else did those sort of things. It didn't ever seem like even a realistic thing. Not that I didn't think I could do it. It just wasn't even in my vision of something to consider. And there's probably things like that still that, kind of keep yourself open, find out what I think it's important to find out what you don't like more than it is to find out what you like. And then just kind of be open to what opportunities come up. And, I think people who go in with a very stringent idea of what they want to do may kind of close their eyes or not be aware of opportunities that are out there that might be more rewarding than what they chose.
So now that we kind of talked about how and why you ended up as a surgeon, can you give us a job description of like, what does a cardiothoracic surgeon do?
Basically, we operate on anything in the chest, the heart, the lungs, and the esophagus. And we're trained in adults and pediatrics, but most of us have to choose. If you want to do pediatrics, you really need to focus on that. So I do adults. And anymore, sometimes people have to choose between thoracic surgery, which would be lung surgery and esophageal surgery, or heart surgery. And part of what appealed to me about the practice here at Mosaic is I got to do all of that. Now, we don't do some of the more complex things like heart transplants and assist devices and things that are at big academic centers. But we do pretty much a wide spectrum of, bypasses, valve replacements, lung cancer surgery, and other things. We don't do esophageal surgery here much anymore, just because there's not very much of that. And that has been really shown to patients need to go to what are considered centers of excellence, people who see something more than just a couple times a year, so that the surgeons and the nurses and the people taking care of them are skilled at doing that. So that's something that we will typically send to another institution.
All right. So you talked a bit about the type of procedures you do. How would you describe a bypass, and what does a surgeon do when they're doing a bypass surgery?
So a bypass is to provide better blood flow to the heart. So Savannah's dad is a cardiologist and does stents. So say you come in and you have a heart attack and one of your blood vessels is completely closed. Typically you'll go to the cath lab, and if it's a blockage that he could fix, he'll open up and put a stent and get blood flow restored. Sometimes we have to take those patients emergently to surgery because they're unable to get the blood restored, and we need to do emergency bypass or sew a new blood vessel past where that blood vessel is blocked. But more commonly is they'll find patients have a lot more than just one or two blood vessels that are involved, and they've got kind of disease in all of their blood vessels. And that's really where surgery's been shown to have the most benefit for people. And we take blood vessels from other places in the body, the leg, the mammary artery that runs on the inside of the breastbone, and stitch them past the blockages in the heart. We use usually a heart-lung machine, so where blood is sent to a machine that oxygenates it and takes the carbon dioxide out and sends it back to the body, so that we're able to actually stop the heart while we're stitching the new blood vessels on. Sometimes we don't have to stop the heart, but usually we do. And that's probably our most common operation that we do. Valve surgery would be our next most common, or sometimes we have to do them at the same time. Somebody who has a leaky valve or a valve that's too narrow and doesn't let the blood out of the heart properly, where we have to go in and put a new valve or repair the valve that they've got, and then sometimes do bypasses or other surgeries that might be needed at the same time.
Okay. So obviously you work pretty close with cardiology. What other health professions or departments do you work with?
Pulmonary and critical care medicine, we work very strongly with, both for our lung cancer surgery and for some of these patients are just very critically ill and we need their help in the ICU. So the doctors that specialize in managing ventilators and managing critically ill patients, we will work very closely with. In addition, the oncologists and radiation oncologists for our lung cancer patients, we kind of work as a great big team to figure out what's the best treatment for those patients. We meet once a week in a multidisciplinary meeting where there's the surgeons and the pulmonary doctors and the oncologists, medical oncologists, radiologists, pathologists, everybody that really would have something to do with lung cancer. And can kind of evaluate a patient's case and come up with a a plan rather than making the patient go to 8 different doctors for all these different opinions. We can kind of meet as a group and usually help more quickly get them through the system to whatever treatment they need.
Okay. So you probably don't have a typical day, I would imagine. What does a typical week look like for you?
So, well, for me, I have clinic once a week. So, and my partners too. We each have one day a week that we try not to operate, and we see patients in the office. For me, that's a Thursday. That's also the day that we do our multidisciplinary meetings. So I'll typically get here about between 6 and 6:30 and see anybody that I have in the intensive care unit. And then the meeting starts at 7. And then I'll try to get patients that are in the hospital seen after that meeting. And then I go to the office, and usually I'm seeing patients from about 9 till 3:30 or 4. And then sometimes that's a day I might be on call, so I might have new patients to see when I get done with the office. If I'm good and keep up with my charts as I'm doing clinic, then when I'm done with clinic, I could potentially go home. But usually something happens that slows me down. So quite often at the end of a clinic day, I'm there getting my chart work done. And my hope is to get home by about 6 o'clock at night on clinic days. Other days are different. There's a lot of days I'm on several different committees in the hospital. So usually our meetings are about 7 a.m. I have one that starts at 6:30 a.m., but that's only once a month. And then when meetings are done, then that's when the operating room starts. And it kind of just depends on the day of the week, what the schedule is. There are certain days that my partners and I have kind of divvied up the access to the operating room, so that, like, for me, Wednesday is my main operating day. But sometimes people need surgery on other days. And then we also are doing TAVRs, the new heart valve that we put in through the leg, in combination with the cardiologist, and we do those on Mondays and Tuesdays. So surgery can just be quite varied. And some days, like today, Dr. Geronimo did the TAVRs first thing in the morning, and I did a heart surgery that started around noon. But I got to the hospital about 8 and saw patients and did a little paperwork, and then did my surgery, and then was done. I think I was home like by 3:30 today. So today wasn't a bad day. There's 3 of us, and so we split the call. So we're on call roughly every third night. It's not exactly every third night, because sometimes somebody has something they need to do. But if you were to take the year, we take roughly a third of the call and a third of the weekends, and we divide up the holidays and kind of rotate on the holidays so that it's fair and nobody gets more. I try to be very fair so that our call is the same and our numbers of weekends are the same, and that you can know that if you worked Christmas this year, you're not going to work the next 2 Christmases and things like that.
So being a surgeon is probably not for someone who wants a simple schedule, then, you would say.
No, you have to be flexible, because people don't get sick just between 8 and 4. And sometimes they need it in the middle of the night, and sometimes they need it on a day when you're not well rested, or you might not be feeling super good, or it might not be your day to take patients, but they want you. So you have to be flexible, and your family has to be flexible, because sometimes this, my kids are all grown now, but sometimes this would, come into dinner hour, or helping kids get homework done, or missing out on school programs. But that was the other reason why we stayed in a small town like St. Joe, was that I was better able to control my schedule, so I could be to more of the kids' things than I would have in a big city.
Good point. So how many hours do you think you work in a week when you're on call versus when you're not on call?
So, when I'm on call, I guess I'm technically working all of the hours, although I'm at home many of those. If I was looking at how many hours do I spend in the hospital actually working, it's probably, typical work week is about 80 hours.
Right, so you definitely have to be willing to work hard and lots of hours to be a surgeon.
Yeah.
Can you talk a little bit about the education and training it takes to become a surgeon, like med school out through residency?
Sure. So for mine, the training has changed because for me to do cardiothoracic surgery, I had to be eligible to take the boards of thoracic surgery. And to be eligible to take those boards, you had to be board certified in general surgery. So I did, 12 years of high school, 4 years of undergrad. I didn't get in the first time I tried for med school. So that year I worked for the county road department and figured out that I needed not to work for the county road department the rest of my life. Then med school was 4 years. Surgery, the residency that I did was 6 years because we had 1 year of research in it, but there are surgery residencies that are as short as 5 years. Some are as long as 10 years, and usually that's because there's a lot of research built into it. And then cardiothoracic surgery for me was 2 additional years. The training has changed. There's still the traditional route where you do general surgery and then cardiothoracic surgery when you're done, but they have a combined program now where you can match into a 6-year program right out of med school called an integrated program where you do 3 years of general surgery and 3 years of cardiothoracic surgery. And at the end of that 6 years, you're eligible to take the thoracic surgery boards. You're not a board certified general surgeon, but they took that requirement away, so you don't have to be anymore. So that is appealing to, there's getting to be more and more training programs like that because they were finding the training was long enough that it was, kind of keeping people from doing it, or especially women who wanted to have kids may have decided not to do it because it was, you're kind of doing your training in the middle of your peak egg producing years. So.
And then kind of to go off that, how do you balance your busy schedule and keeping up with your family? I know that you have a pretty big family and lots of kids.
It was a bit crazy. I mean, I give the credit to my husband because he took, kept things working when I wasn't here, which was a lot. But I had my first baby. We got married when we met the end of my senior year of med school. We got married my intern year. And then I had my baby at the beginning of my second year of residency. My third year of residency was my research year, and that's when I had my son, which actually, the research year was more like an 8-to-5 job, and it was actually more manageable to have a baby that year. And then I got surprised with twins. We were planning on having one more baby, and we were going to do it the second to last year of training, and then we had twins. So that threw us off a little bit, but we were able to hire a sitter that came in the house and with creative daycare kind of kept things together. And I had a stepdaughter that was 13 or 14 when the kids were there. So she helped a lot coming over and babysitting and staying with my husband when I was in the hospital on call. But it was a very chaotic, crazy, you lived through it a bit too as a kid of a doctor who was training, that I tried to be there as much as I could, but I wasn't there as much as would have been ideal. But my husband kept up the end of what I wasn't able to do.
Yeah, I think it's kind of important to kind of notice that obviously a career in surgery is a great career, but it definitely does have some potential drawbacks if you're someone who really kind of wants to have complete control of your schedule.
Yeah.
You were talking about Michael. What are some of the differences between Michael applying to medical school and you applying to medical school? What were some of the things that he did different that you didn't necessarily have to do?
Some of the requirements for med school, like all of the, like the AHEC type programs and the job shadowing and all of the pre-medical school experience that they expect of you all now, that wasn't a thing. They liked it if a lot of people would go like volunteer for a couple hours a week in an emergency room or in a pediatric ward or something like that, but it wasn't a requirement. And it certainly wasn't the mandated super number of hours that are there. I think it was probably as competitive back then, but a different type of competitive. Obviously, it's all automated, it's all electronic. I mean, I had to sit at the old-fashioned typewriter and write out my personal statement, and everything was mail and telephone calls, and so it was slower, and so that was different. He actually took 3 tries to get into med school. He ended up doing a master's program in anatomy and then got into med school. And I think the thing I learned from myself, the reason I didn't get in the first time was I was in Washington, and we just had one medical school, and that's the only place I applied to because I didn't want to move because I had a boyfriend. And University of Washington only took its own students, and I didn't go to University of Washington, and I didn't know that. So that was an error on my part of just not being very educated. So the second time, I'd applied to a bunch of schools, and he applied even more. I think the numbers of schools that people are applying to are, a lot. And it's a lot more costly now to apply to med school or to residencies, all those secondary applications and things. And the tuition cost and all of that is just gone way, way higher than it was back when I was there.
What advice would you give to someone who has applied for school but didn't get in their first try, or maybe even their second try?
Is to talk to the schools and find out what was missing, what was lacking in your application. Was it your MCAT scores? Was it your undergrad GPA? Was it your references? Was it lack of volunteering or job shadowing experience? Was it, do you come off as a jerk when you interview? Find out what the skills are that we're missing or lacking. And a lot of times I don't know. I think some places just play games with kids, but want to make sure that you're doing it. I think especially students that are students of doctors, you have to really show or prove to them that you're doing it because that's what you want, not because your mom and dad want you to do it, or you're just doing it because, my dad's a doctor, I'm going to be a doctor. But why knowing specifically what it is about you. I think the personal statements that people write to get into med school are incredibly important. And you certainly don't want to lie, and you don't want to be grandiose about things that happen to you. But if there's something that really sticks out about you that's different than the average student, or experiences, or something that you can put into words that really set you apart from other students, I think those are important to highlight, without being braggy, and, sounding off-putting about it, but really, what makes you special, and why should they take you over the 6,000 other applicants that they've got?
What is a common misconception about your career?
Well, not that I'm the world's nicest person, but I think that you always hear what horrible, awful people cardiac surgeons or surgeons in general are. And I think my partners are super nice people. And so I don't think you have to be a jerk. In fact, I hope that if you're a jerk, you don't go into medicine in general, or don't go into surgery, because I think you need to be kind-hearted and a good, caring person to take care of these people who are entrusting your lives at a very fragile point. So that's probably my biggest think that there's a misconception, not to say that there aren't jerks out there, but we're not all that way. And not every heart surgeon is a man, and not every heart surgeon is white. We come in all sizes, shapes, ethnicities, gender identification, all of that. So.
What are some of the other soft skills? I mean, I know that you talked about like kindness and not being a jerk, but what are some other soft skills that they can be kind of working on to help them prepare to be a surgeon or doctor?
I think just in general in medicine is to learn how to listen and learn how to ask questions, to really listen to your patients and pay attention to what they're doing, to their body mechanics and the kind of the vibe they're giving you of what they're saying. Listen and look at the family members that are in the room, because quite often I get more information from them than I do the patients when they tell me that, oh, they've never had pain before, and the wife over there rolling her eyes. And So and to just be a humble, you're just a person and they're just a person, and you just happen to be a person who has the skills that they might need. That person needs your help, but you're still just two human beings, and to just talk to them on a human to human level and find out as easily as you can their side of what's going on. And then in your job is to explain what you think is going on and what needs to be done in a way that they can understand. So learn how to speak, I don't want to say dumb it down, but pretend you're talking to your mother and trying to explain to her what needs to be done in a way that she's going to understand, and take all the medical mumbo jumbo out and just talk like a normal person to them.
Okay, cool. How has your career changed in response to COVID?
Well, when COVID first happened, they recommended that we didn't operate on anybody that any elective surgeries. So from April and May of last year, we did really only urgent or emergent surgeries, which most heart surgeries they can't wait a year. It's not like a hip or a knee that they can wait. They're not going to die if they don't get their hip or knee. We can only wait so long. So some of it was learning how to have to shuffle, I don't want to say allocate care, but kind of, we have 5 people who need surgery, who needs it the most, and how to get those most urgent cases done. Not only limitations as far as number of operations we could do in the operating room, but beds in the hospital and beds in the intensive care unit. For a while, off and on for the last 18 months, we've had no beds for an open heart, and we've had to not be able to do one, or they've had to call in extra nurses and float ICU patients other places in order to get things done. So it's just been a lot different. We used to, unless a patient wanted to wait a week or so, we'd usually get surgeries done within a few days. And anymore, it's, people are waiting a couple weeks. Nobody's waiting to their detriment. Nobody that absolutely needs it has had to wait, but some of the more elective things we've had to, put out for a couple weeks. And this week, for a while, not all COVID, but a bit COVID related, we're short on anesthesiologists and anesthesia providers. So we don't have as many rooms as we normally do this last 2 weeks. And so we've had to shuffle things around this week because we just didn't have the doctors necessary to not just do the surgery, but people like to be asleep when they have their surgery. So
you talked about staffing issues and just some other COVID restrictions. Are there any other challenges to COVID that you experience as a physician?
The vaccine denial is a huge problem. People with I'm getting a little bit because the sun's figure out where I'm not in the sun. People who have heart surgery who get COVID during their recovery have a 20 times higher chance of dying, which we knew that. So back before vaccines existed, we just had to have that discussion with people that they need to wear their masks and be distant and all that sort of stuff, and limiting visitors and things. And now that vaccines are here, I would say 75% of my patients have gotten vaccinated, but there's quite a few of them that haven't and aren't going to. And so trying to sort that with them, how to keep them safe and understand that it's not just the fear of them getting COVID, but if they get COVID during their recovery, they go from having a 1 in 100 chance of dying to having a 20%, 20 in 100 chance of dying. I've lost a few patients because they got COVID during their recovery. And it's heartbreaking because it's heartbreaking in general to watch people struggle with COVID, but it's heartbreaking to watch somebody who you knew had a procedure to try to better their life and better their quality of life. And then a disease comes and gets them that shouldn't have, and they die.
So I know you probably do experience some traumatic events. Talked about losing patients to COVID. can you talk a little bit about like some of the more traumatic events that you experience as a surgeon and some of the resources or things that you kind of do to help with that?
I mean, obviously the most traumatic thing is somebody who unexpectedly dies under your care. Taking somebody to surgery who is dying, we know that they have a higher chance of not making it through the operation or making it through to go home. And it's still hard to lose that patient, but you knew ahead of time that they were risky. The ones that are the hardest are the ones that have some unexpected fluky complication and don't make it. And those are really, really hard on the surgeon and the team. People who had a few who've had, severe anaphylactic allergic reactions to some of the medications we give in surgery, and their heart wouldn't come off the heart-lung machine because of it. So those are traumas. We've had some traumas where there have been missteps by people in the operating room, or somebody being given the wrong something, or something that went poorly that shouldn't have, because somebody made an error. And those are very difficult. And it's very, sometimes those are things where somebody needs to lose their job immediately, but usually it's something that the system didn't work well and we have to immediately, address. So there's a lot of process in the hospitals to keep people safe and to address if something didn't go well, and we implement that. And then there are like psychological resources for every employee right now, and they're pretty unlimited with the days of COVID. There's counselors on site that anybody who needs it can have unlimited counseling visits. Nationally, there are national physician hotlines, so it's anonymous that you can talk to and kind of go over things. I'm on a lot of different doctor Facebook groups and societies and things where we can share and learn from each other, and kind of reach out. I'm in close contact still with the people that trained me back in Seattle, so that if I have tough cases, even though one of them's almost 80 years old, he still answers my phone calls and helps me think through things. So
awesome. And I like that you mentioned that the whole connection thing is a really good way to kind of overcome that trauma, because it is a team. I mean, medicine is a team sport. So
yeah, it definitely is. And it's not just hard on the doctor. The nurses take their job super seriously. Everybody does. So
yeah, good point. We'll have a couple of fun questions to round us out. So what is the most satisfying thing about your career?
I think the most satisfying thing is seeing people recover from whatever I did, their lung cancer surgery, their heart surgery, and then run into them randomly, years down the road. I'll see, there's some people who, a girl that I replaced her valve when I lived in Kearney, so it's been 24 years ago. We're friends on Facebook, and she will call me when she has a sore throat to ask about, if these meds are okay for her heart and whatnot. And so to just kind of have that connection with people and see them recover and go on. Sometimes it's just as rewarding, those patients that you're helping transition at the end of life, trying to make the end of their life as meaningful and unpleasant as possible. It's hard to lose them, but it's good to be part of something that helps that family and that patient come to terms with things that when there's not anything that can be done.
Yeah, and I think it's important to note too that I think it's a lot easier to have good patient relationships when you are a small town physician.
I think so.
You're going to be seeing basically the same people forever.
Yes, and half the time you work with somebody that they know. There's also, there's no place to go and be anonymous. If you go to the grocery store, somebody's going to judge what's in your grocery cart, or you go out to dinner, somebody's going to notice if you're drinking or whatever. So there's, some things that you give up living in a small town, but you can go to a big town like Kansas City and nobody knows you and you can do whatever you want to do.
Good options. How do you impact lives with your career?
Besides my job, I mean, I've tried to get involved in the community. Not just me, but a group of us started the Clean Air St. Joe thing. And so 5 years ago, helped St. Joe put a smoke-free initiative on the ballot. So nobody smokes in the bars and restaurants in town anymore. We had a program which was probably my favorite thing outside of surgery, was fourth grade challenge that we did, where we went into the grade schools in town in Savannah, and we were just starting to go into mid-buck when COVID happened and we had to stop. But teaching kids in the fourth grade about exercise and nutrition and how to take care of their bodies. And it was just starting into recognizing the importance of mindfulness and mental health and doing yoga with the kids and things. So that was probably my favorite thing that I did. But I've enjoyed, being in the community and trying to better the health of the community and the health literacy, the people understanding how to live a better, healthier life. Not always successfully, because people still smoke, but I'm still trying.
Oh. And so how do you think, or do you think that your community involvement makes you a better physician? And if so, why?
I think it helps me know a little bit better about our community and know the vulnerabilities of the community. And I learned a lot about racial, socioeconomic divides in Northwest Missouri, within St. Joseph, and comparing us to cities like Kansas City that are geographically close but look nothing at all alike. So yeah, I think just knowing the kind of the finances and the struggles that people in this town have makes a difference, as far as even like what medications I prescribe. Trying to know what is affordable and what pharmacies sell things at the least expensive prices for people, so that because medicines only work if they get in your stomach, and if you can't afford them, it doesn't do any good. So that sort of social aspect and the social determinants of health have really impacted how I practice and take care of people.
And last question, and then we're going to have the students ask questions. So you guys should have been asked to unmute. So if you have a question, please unmute yourself and raise your hand, and I'll call on you guys. But last question for me is, what is some advice that you have for these students?
Would be anything that you think you're interested, no matter where you are. See if you can plug yourself in with somebody like that. If you think you might be interested in psychiatry, use you guys have huge access here through AHEC. We can plug you in with just about anybody in any specialty, and even specialties that might not be at Mosaic, but we all know somebody at other places, so we can help with that.